So I think it's 11 o'clock now. More people might join in, but I think I'm going to start with the introductions and, um, my name is Ngozi U for those that um, want to learn how to pronounce it. It looks difficult, but it's really not a difficult name to pronounce. So it's Nigerian name, and I'm a physician in occupational and environmental medicine. I am in Milwaukee, Wisconsin, and I work at Frederick Medical College of Wisconsin. So I'm just going to go ahead and share my screen so we can go into the presentation proper. So we're good today. This is the third installment of our virtual Symposium for medical students. And I'm an ACOEM ambassador. So it's presented by the ambassadors of American College of Occupational and Environmental Medicine. So it's a way to introduce you to our specialty, talk to you about what we do and the different kinds of practice we have. It's one specialty, but there are different aspects of it. There are different things you can do in a specialty. And all of them look different, all of them, but it's still the same medicine. We practice in different sectors of the economy and industry. So my journey into occupational medicine went through doing internal medicine residency, preventive medicine residency, before I discovered occupational medicine, and I completed a residency training in it too before I came to Wisconsin. I trained at University of Colorado. And I work at Frederick Medical College of Wisconsin, which is a level one hospital and one of the premier health institutions in Southeast Wisconsin. And we have a medical school, but we do not have a residency training in occupational medicine. But one of the things I've really enjoyed doing is to bring occupational medicine into the medical school curriculum and to really introduce the medical students to what occupational medicine is and what we do and how fun and interesting it is and how much you will enjoy your career in medical practice through occupational medicine. So my department of occupational and environmental medicine has 7 clinics. I do clinical and corporate occupational medicine practice, environmental health, exposure management, and hazard evaluation. So day to day for me is clinical practice. So one thing about medicine is the same, whether you are in the clinic in occupational medicine or you are in a clinic in internal medicine, it's still the same medicine. The only thing that distinguishes us is how this medical care is administered, who pays for it, whether it's paid by Medicare or Medicaid or through the workers' compensation insurance, which is what pays for the services we provide. Other services we provide for employee health are covered by the employer directly. So I do consulting and medical surveillance, helping to develop corporate health processes, policies for companies and industry. I do medical qualification and certification exams for police, firefighters, coast guards, general industry employees, and for health workers. I also teach, like I said, we have a medical school, Medical College of Wisconsin, and I really enjoyed teaching them occupational and environmental medicine and how that could actually enhance their medical knowledge. Because when you understand how occupational and environmental exposures can impact the health of your patients and their disease conditions, you're able to fully understand how to help them and to manage their conditions better. So the interesting case I'm going to talk to you about is a case I had in January of 2023. So it was a case of hazardous dust exposure to an individual. So this is a linear accelerator engineer in the radiation therapy. So he came to see me he wasn't having any symptom. He was just told by the employee health and safety that he needed to come and see me 2 months after the exposure. So the exposure happened on September 1st. And then he was told, notified in November 2022. And then he couldn't come to see me until January of 2023 because of the holidays. And then he had to travel with his family. He had other conflicts and couldn't make it to see me until January. So by the time I was seeing him, I was asking him, how did this exposure happen? So he told me that during a safety evaluation, in every department, especially nuclear medicine, radiation, oncology departments, they usually have routine investigation by physics groups that come to monitor the equipment, make sure that the employees are not getting exposed to radiation or toxic materials that could harm them. So during those investigations, they usually ask them to demonstrate what they do, what their job is. So he was asked to demonstrate the use of a belt sander. So the belt sander is usually used to sand Cerrobend. So Cerrobend is a metal alloy that is used to make radiation molds, for blocking radiation when doing radiation therapy, to protect the body so that the radiation doesn't kill the normal cells and tissues during radiation therapy. So he was asked to demonstrate that. And when he did that, the belt sander created a lot of particulate matter and generated bits of the metal, so, and it got all over him. He was not wearing any PPE per se. He only had a surgical mask because if you remember, 2022, 2021, there was still some COVID, people we were still masking at that time. So he only had his mask on and his prescription glasses and a pair of nitrile gloves. That was all he had. The process of standing lasted for about 1 to 2 minutes. And during that, after he did that, the inspection group collected samples. They collected wipe samples from the deck surfaces, from the belt sander, from the surface where he was working, and then they asked him to vacuum the surface using a HEPA filter vacuum. And after he did that, they also collected post-vacuuming sample. So this will move. Okay, I can get my slide to move. All right. So I've talked about Cerrobend a lot. So let's back up a bit and tell you what Cerrobend is, because it's good for you to understand what we're talking about here. So Cerrobend is called Wood's metal or Lipovitz alloy. So it's an alloy made up of bismuth, lead, tin, and cadmium. And you can see the percentages. It's usually used for making custom shielding blocks or devices for radiation therapy, like I mentioned. So it's a metal with a melting point of 458 degrees Fahrenheit or 70 degrees Celsius. It's also used in machining and in industry as well. So it's used to make molds, like I told you, and these molds are made based on specification by dosimetrists and specialists that work in radiation therapy. And then they create the molds using to fit the part of the body that is going to be protected using a styrofoam mold. And then the solid Cerrobend is put in a vat and then heated to melt. So this is the Cerrobend that is melting. So after it's melted, it's poured, it's taken, this heating is done in a hood, in the laboratory hood, to prevent it from getting all over the place and exposing the workers to it. So it just takes it out of the room and, siphons the air out through the vent and it goes out. So after it's melted, the molten Cerrobend is now poured into the mold, that styrofoam mold, to make the shape that you need to protect the body parts that it's intended for. So after it's done, the Cerrobend is taken out when it cools down and sanded. So that's the sanding. This is not the actual sanding of Cerrobend, but it's this type of sanding belt that they use. So when it's sanded, you can see some sparks flying off at the bottom. So that's the kind of thing that this is not the exact image of what happened, but I just tried to find something to illustrate what I was trying to say. So it generates particulates that get all over the place, and that was what happened to this person. And there's some quality control that is done on the molds to make sure that they are properly made. There's no sharp edges that could harm an individual. So that's what the sanding is for, to smoothen the edges and make it nice, and then it's packaged to be used. So this is an example of the Cerrobend shields used for oral cancer treatment. So you can see the mold with the Cerrobend placed in it, and then the shield, Cerrobend shield inside the mouth of the person that is going to have radiation treatment. The same thing here in the second picture, showing you how the mold is placed in the mouth for somebody that has cancer of the buccal cavity, squamous cell carcinoma, that is going to have radiation treatment. So let's go back to our patient now that we know what Cerrobend is. So our patient had this exposure. They collected air samples and it was tested, and he went about his business. He didn't have any symptom. He didn't have any problem. He didn't tell anybody. He didn't even report it because that's usually what happens. That's how they were working. He felt there was nothing wrong. And so from that time until the time I saw him in January of 2023, which was like 4 months later, so he said he didn't have any complaints. He was still doing his work. The only thing he complained of was he admitted he has some joint pains, usually especially in his right shoulder. He's had that for about 2 years at that time, on and off joint pain. He's had some physical therapy and treatment for that. Denied any other chronic health issues like kidney problems, iron deficiency, diabetes, high blood pressure, kidney problems. He admitted he has bilateral hearing impairment from years of working around heavy and loud machines. So he wears hearing aids. He has narcolepsy and he takes Nuvigil for that. He also has GERD, takes omeprazole, and has hyperlipidemia on statin for that. He's up to date on all his health screenings and health maintenance, except RSV vaccine. He admitted the multiple joint issues, especially the right shoulder, history of benign paroxysmal positional vertigo that resolved years ago with vestibular therapy, as well as diverticulosis that was found when he had his colonoscopy. He has a history of torn right biceps tendon that was repaired in 2021, remote history of surgery in the knee. He had obstructive sleep apnea and had oral surgery to repair that. And after that, his repeat sleep sleep study was negative. He's also had surgery for hand fracture and no known drug allergies. He never smoked himself, but he said that his parents were heavy smokers. They smoked all their lives. And in those days, people that were born in those days, almost everybody smoked at that time. Both his parents smoked. 8 out of his 11 siblings all smoked. So despite him not smoking, he was exposed to a lot of cigarettes, secondhand cigarette, and possibly third-hand cigarette smoke exposure. He drank heavily from his high school until he was 30 years old. After he got married, he only drank at events for toasts. And he lives in a environmental history, lives in a single family home with his wife and daughter, and no pets, no remodeling, no exposure to asbestos or lead or anything, no hot tubs in the home, no molds, pest infestation in their home. I just mentioned his family, had heavy smoking history. So his mother died from lung cancer at 76, father died from prostate cancer at 80. But prior to that, he had hypertension and coronary artery disease. Other family members have, health issues as well. He has worked in several industries, starting from when he was in high school, and he said most of those places had very loud noise exposure, like working as a bartender or in a restaurant where there was music and loud noise all the time, working in construction, working in as a painter in a company, and using loud equipment. He also worked in biomedical field. For the last 40 years, he said he had worked as a linear accelerator survey engineer, and 9.5 of those 40 years he had worked with the current employer, which is our hospital. He maintains and operates equipment used in radiation therapy. I'm still having issues with moving the slide. Okay. So review of system was negative except for the joint pain, and his physical exam was essentially benign. There was really nothing. So now that we have this exposure, do we really have a problem here? He doesn't have any symptom, but he had an exposure. So how do we know that he has a problem from this? Or what problem do we even think he has? So when there is an exposure, the first thing is to find out what somebody is exposed to. And you have to understand the difference between association and causation. So association is when there are chance of multiple things, something is likely or possible, or this could happen as a result of this, but there's no definitive link between them. Their link could be due to chance, maybe two or more variables contributing to something happening. But causation is when there is a definite dependent relationship between one thing directly leading to another thing. So we're going to also go back to this when we get back to the result of the air sampling. So that's another thing you have to also, when we now get down to causation, there are factors that can make something cause something. And when something can cause something, there are precipitating factors, predisposing factors that the person is coming to the table with, enabling factors around the person that can facilitate the problem getting worse, and reinforcing factors that will continue to re-expose that person to the same cause of the problem. So back to the air sampling that was done on September 1st on the day of exposure. One thing to understand is that in occupational health safety, the U.S. Department of Labor, under which Occupational Safety and Health Administration is housed, develops and enforces regulations and standards for monitoring and maintaining and evaluating the health of workers. So when somebody has an exposure, there is OSHA standards. So that's what Occupational Safety Health Administration stands for, OSHA. So they developed these permissible exposure limits, the level of exposure to toxic substances that are allowed for each hazardous substance. They also establish action levels, the levels at which an employer should take an action if somebody is exposed up to that level. There's another agency called National Institute for Occupational Safety and Health. They develop recommended exposure limits. So they are more of a research institution that develops exposure limits and recommendations that Occupational Safety and Health Administration uses to develop enforceable standards that can be applied to industry. So the results of his test showed that only cadmium, remember, Cerrobend has tin, bismuth, lead, cadmium as its components, as well as particulate matter, but only cadmium was the one that met the OSHA level. The concentration of lead and tin and bismuth and particulate matter in the air sample were below the OSHA levels, OSHA exposure levels. So only cadmium met the action level, but the level of cadmium was also below the permissible exposure limit. But because of the fact that the concentration of cadmium in the air was up to the action level, action needed to be taken for this employee. So now that we have this, so what do we do with this? Remember, the patient doesn't have any symptom yet. So this is the medical surveillance recommendation by OSHA according to the standards that they have. So they have normal levels of, they have levels where different biological tests have to be, and they specify the type of biological testing that has to be done when somebody is exposed to cadmium. So when somebody is exposed to cadmium, you have to check the level of the blood cadmium, the urine cadmium, and the urine beta-2 microglobulin. So beta-2 microglobulin is a protein that is also spilled out in the urine because of the effect on the renal tubules. This protein starts leaking out into the urine. So if those are high, any of them is high, then there's a problem. So note those because those will come up later. So now, go back to how do you, so I remember I told you that this guy is asymptomatic. Now that the first thing to do is identify what the problem is. We've identified that he got exposed to a hazardous substance, a hazardous dust containing cadmium. So we've identified it. The next thing to do is decide who might be harmed. Is he harmed? So we've had this employee that was exposed, we've identified him, so we've done 2. So now 3, we have to evaluate the risks. What are the health risks he's going to have? What body part or what type of test are we going to do? Are we doing CBC, CMP? What are we testing? So that's what the OSHA standards has already told us what kind of test to do. And then after we test, what do we do with the results of our test? How do we record it? How frequently do we do it? Do we do it every 6 months, every year, every 2 months? How frequently do we do it? And how do we record it and what happens with the results we get? So that's what we're going to get into as part of the medical surveillance. So this is the result. So I remember I saw him on January 23rd. So I ordered the test and I got the results back. So his blood cadmium was less than 1. His urine cadmium was less than 1, and urine beta-2 microglobulin was 40. So normal is less than 300. This one is less than 3 and less than 3. So he was below the level, the normal level for all of them. The rest of the tests were, I also went ahead and did tests because um, some conditions can precipitate or exacerbate the impact of cadmium exposure, things like iron deficiency anemia. So he had mild anemia. It wasn't that terrible. So, but it was normochromic. There was no sign of microcytosis or anything. So iron deficiency was really a concern at that point. So I didn't bother with doing additional tests. The rest of his tests were all normal. And so we made an assessment of occupational exposure to cadmium. And then based on the fact that he had all normal results, his risk is very low. So the risk of exposure to this toxic substance is so low that there's no likelihood of any organ damage for him. So this is what the OSHA standard said, and that's why I put the arrows there. So if all your levels are below, urine cadmium is less than 3, blood cadmium is less than 5, beta-2 microglobulin is less than or equal to 300, all of them are normal, and you don't need to do so. Negligible problem, provide annual biological monitoring, and by every 2 years you do physical in-person medical examination. So that's what the standard recommends, the action that I was advised to take. So I did not have to do any other thing. So I recommended for him to come back the following year to repeat the annual test, those 3 tests in 2024. So in 2024, he comes back and this is what we got. So blood cadmium was still fine, urine cadmium was fine, but there's a problem now. His urine beta-2 microglobulin was now 405. Remember, normal is 300 or less. So this has become abnormal. So although he was still asymptomatic, he said that they had made some changes. They have put some additional hood in the place so that the Cerrobend now goes out. It doesn't get exposed to them. So because of this abnormality, I had to put in a nephrology referral, and then I had to do further testing because now I had to find out what is going on. Why is he having abnormal results? Has he suffered any renal impairment or kidney problem as a result of this? So back to the OSHA standard. This is what is recommended if you have abnormal level for any one of the measurements that is at an elevated level. This is what you do. So the person is now at a higher risk of renal and tubular proteinuria and damage. And remember, the reason for having the beta-2 microglobulin leaking out into the urine is because the tubules are becoming more leaky. That's why you're having all that being spilled into the urine. So you now have to provide twice yearly biological monitoring and annual medical exams. So that's what we did. So further recommendation is so I put in the repeat test for him, which were done. I also went ahead and evaluated him for bone lung damage because cadmium can cause lung disease, bone disease, iron deficiency can exacerbate the effect of cadmium exposure. And then I also went ahead and checked him for lead because remember, we had some lead exposure, but it was just because the lead in the air was small. But one thing you have to understand about lead is there's no safe level of lead. So I went ahead and evaluated him for lead exposure. So his test came back and showed the lead exposure testing were all normal. The only thing is he had just a mild elevation of the ALT and every other thing. The anemia had also worsened a little bit because remember his prior hemoglobin was 13.6, now it's 13. So it went down a bit. And then the repeat test was done for the cadmium exposure. At that point, blood cadmium was still normal, urine cadmium was normal, and beta-2 microglobulin had dropped. So it had dropped to 2.1, which is normal. So at that point, everything had come back to normal. His hemoglobin improved a bit to 13.6 at that time. And then nephrologist saw him the following month in February of 2024, and all the tests showed were all normal. Beta-2, everything had normalized at that point. So he was to be seen in 6 months, because remember, he had to be seen 2 times. So it was done, and all the tests were still normal. So he returned to work. We also emphasize the importance of maintaining all these measures, safety measures to reduce further exposure to the employee, to the case manager and his direct boss. And then medical surveillance tests for 2025 were entered. So in 2025, January, we did test again. All the 3 tests were all normal. All the CBC, CMP, the liver test, hemoglobin, everything was back to normal. So everything was fine at that point. And then I saw him in clinic. He was still doing fine. And by that time, he had already been removed from that work site. So he no longer handled Cerrobend, but he said that other employees were still doing the process just like they did after they made all those changes, and they provided additional personal protective equipment for them. The only complaint he had that time was some tenderness over the left index finger, but that was all. All the other exam and physical exam findings were normal. So final recommendation. So by 2025, that was the second year we're having a second normal results. Remember, according to OSHA standard, if you have normal results for 2 years, by the second time you're getting, by the second year of normal results, you can discontinue medical surveillance. So he had remained normal for the second time. That's 1 year after the last normal results. So there was no need to continue further medical surveillance. So we discharged him with additional recommendations to keep himself safe and prevent further adverse effects from any further exposure. So that was how that case was managed. So now let's talk a little bit about cadmium, because that's the major agent, because so that you understand why we were doing the test we were doing for him. So cadmium is a soft transitional metal. It's very used for galvanizing. It's used in industry. One of the commonest sources of cadmium is commonest uses of cadmium is in electroplating and also in battery manufacturing. And because of this, when these types of materials, especially battery, are discarded inappropriately, if they are discarded with household waste, they can go into landfills, they can go into the soil, they can go into the water sources and contaminate the environment and contribute to high levels of cadmium in the environment. But most people that have gotten exposed to cadmium have gotten it through their job. Other people have also gotten it from smoking. In fact, if you smoke 1 pack of cigarettes, that's that's kind of equates to getting about 1 microgram of cadmium per day. So you can also get it from paints that are made with cadmium pigments. You can get it from fertilizers that have cadmium in them. And when these fertilizers are used to grow food, the food can absorb some of that cadmium. And then when you eat it, you can get exposed to it too. Cadmium can also get into the air, like if smelting factories or industries that use cadmium in their manufacturing process generates the smoke that comes out from their smokestacks, they can get into the air and you can breathe that in and also get inhalational exposure through that. Workers that work in mines or factories that have use cadmium also have high exposure risks. And individuals that live near manufacturing sites that use cadmium in their manufacturing can also get cadmium released through that smokestacks that goes in the air. And when you breathe the air in that environment, because the air moves, disperses further and further, you can also get exposed. Or those that work in farms that use fertilizers or factories that use cadmium, or fertilizers that contain cadmium. If you work with it, you can get exposed if you're a farm worker too. So there are different sources of getting it, but occupational exposure accounts for one of the major sources of exposure. And then the exposure limit as designated by OSHA is 0.005 to 0.005 cubic 0.005 milligrams of cadmium per cubic meter. But in most other countries, they have a range of, they are more permissible, 0.005 to 0.05 in many other countries, but this is a US level, the US standard set by OSHA for atmospheric air cadmium. So how is cadmium metabolized when you inhale it? So remember, you can inhale it or you can eat it through water or food. or going in through your GI tract. So if you inhale it, it's usually more bioavailable. Your body takes and absorbs more of it if you inhale it, because the reason is that if you remember the talk of last week given by Michelle, she talked about PM 2.5 and PM 1 and PM 10, and that the smaller the particle, the further it can go into your lungs, and the further it goes into your lungs, which is where absorption occurs at the alveoli level. So that's the smaller particles can get further down, and that's why the tiny particles of cadmium in the air is more bioavailable, is a more significant exposure if you inhale it than if you absorb it. GI absorption is poorer. Only about 10% of their oral intake of cadmium gets absorbed because of how it's handled. So smaller particles, like I said, make more effective toxicity type. So metabolizing of how is it metabolized? So the absorbed cadmium that eventually makes it into the bloodstream gets bound to albumin. So whether it's inhaled or absorbed through the GI tract, it gets bound to albumin, and then this bound cadmium is now taken to the liver, where it induces metallothionein synthesis. And then after that synthesis of metallothionein, the metallothionein is bound to the cadmium, and this complex of cadmium and metallothionein is now released from the liver and then transported through the bloodstream to the kidneys. So when this cadmium thionein complex gets in the kidneys, they usually accumulate in the proximal tubule. So in the proximal tubule, where they are now accumulating there, this accumulation causes an oxidative damage that results in the formation of cadmium metallothionein complex. And this complex that accumulates here in this proximal tubule is 15 times more nephrotoxic than cadmium alone. And when this happens and this kind of damage occurs in the liver, the urine cadmium at that point exceeds over 30 microgram per gram. Remember, the urine cadmium for my patient was less than 1. But when this type of damage happens, the urine cadmium, becomes very high. And at this point, renal failure can occur. And the type of damage that occurs when this happens is usually irreversible. Even if you do dialysis, at this point, it's usually irreversible at this point, because this complex of cadmium and metallothionein is very, very toxic to the kidneys. So what are the features of cadmium nephropathy? What do you see? So of course, the problem happens at the proximal tubules. So that's where most of the damage happens. So you have proximal tubule dysfunction, a lot of proteinuria, low molecular weight proteinuria, interstitial nephritis because of the oxidative damage to the interstitium of the kidneys. And then most of the patients develop what is called low molecular weight proteinuria, or Fanconi syndrome, which is just leaking out a lot of protein into the urine. And then there's also proximal renal tubular acidosis. And lots of patients have urolithiasis and stones forming in different parts of the urinary tract. There's also risk of calcium wasting, calciuria too, and this also contributes to urolithiasis as well. What are the health effects? The acute exposure, especially when you have acute inhalational exposure, most of the exposures are usually acutely, especially with heavy doses of cadmium exposure. Most of it can be in the form of flu-like symptoms, and person can have fever, myalgia, but there's also lung damage and pneumonitis, lots of coughing, and like flu, as if the person has flu. So that's acutely. But what happens chronically? Chronically, especially over a long period of time, years and decades of exposure, that's when you have the kidney damage, because it takes time for this kind of damage to occur, for enough accumulation of this toxic cadmium methionine complex in the kidneys to occur, resulting in tubular and interstitial injuries. And then another thing that can occur with chronic exposure is bone damage. And the bone damage can be in form of osteomalacia. When the bones are very thin, osteomalacia just means thinning of the bones. It can become osteoporotic and then ultimately result in pathologic fractures. And why is that? Remember, one of the features of cadmium exposure is leaking calcium in calcium wasting. When you're wasting calciuria, leaking your calcium into your urine, you're losing calcium, and then the calcium and that's calcium in your bones leaking out, and that results in osteomalacia, osteoporosis, pathologic fractures, and of course, chronically, lung disease. Apart from the pneumonitis that can occur acutely, chronically you can have things like emphysema, chronic obstructive lung diseases, as well as lung cancer. In fact, the cadmium has been designated as a class 1 carcinogen by the International Agency for International Agency for Research on Cancer. So this agency is under the World Health Organization. It was in 1993 that studies concluded that calcium is a class 1 human carcinogen. So the International Agency for Research on Cancer designated it a known cause of cancer, so direct link between cadmium exposure and cancer causation. So other features like of the bone disease that I was talking about is this. So this is a famous case that happened in the 1910s to 1960s. So in Japan, there's a river called Jinzu River that was contaminated, polluted heavily with cadmium. So that river also takes water to people that plant rice and plant other food grown in that region of Japan. So people living in that area became heavily poisoned with cadmium because another thing is that their food is heavily rice based, so they eat a lot of rice. So people eating all these rice grown in these rice fields that were contaminated with cadmium got heavily poisoned, and a lot of the individuals there developed this disease called itai, which means ouch ouch in Japanese. So because of bone pain, they had a lot of bone pain, and over time, because of the bones becoming becoming soft because of osteomalacia, you had a lot of people's bones bending, becoming deformed to the point where the spine could be bent like that. So it caused a lot of health issues, as well as the kidney damage and other conditions that resulted from that. So the OSHA standard, like we talked about before, we've already talked about this. This is the OSHA standard, the limit for cadmium exposure that you should have. So it should be less than these levels for blood cadmium, urine cadmium, and beta-2 microglobulin. And cadmium is a known, beta-2 microglobulin is an early indicator. When you are looking out beta-2 microglobulin in your urine, it's an early indicator of cadmium nephrotoxicity. So what are the risk factors? Because remember, when we talk about causation, we have the precipitating factors, factors that aggravate a condition, factors that somebody already had before. So some of the risk factors, like if you have some of these factors, they can exacerbate how you're going to be affected by cadmium nephropathy. So one of them is being older, because the older you are, you've lived longer, you've had a longer exposure, many years of exposure, and you've accumulated a lot more of the cadmium in your kidneys. So you're more, and then you could also have gotten it from a lot of sources. Like if you smoke, if you work in places where you've been exposed, like in factories or fertilizer, or the longer you live, the more you're at risk of having a lot more exposures. If you have degenerative damage from other things, other conditions in your kidney, degenerative changes in the tubules can also predispose to cadmium-induced tubular injury, and also exacerbates the damage that will result from exposure to cadmium. And if you have diabetes, because diabetes already causes nephropathy, causes kidney diseases, so you're already at risk of further kidney disease from being exposed to cadmium. If you have iron deficiency, individuals with iron deficiency they absorb more cadmium, compared to those that maybe because of the charge on both of them is 2, so they tend to absorb more cadmium than people that are not iron deficient. I'm having issues with these slides again. All right. So how do you treat it? So like everything else, there's really no definitive treatment for cadmium toxicity. The acute measure for those that have acute toxicity is mostly supportive treatment, If they are having lung disease, shortness of breath, make sure they have oxygen. If they are having difficulty breathing, having symptoms of obstructive lung disease, give them bronchodilators. I'll keep them. If they're having fever, give them antipyretics. So just supportive treatment is really what's given for the acute toxicity, whether it's inhalational or oral exposure. But it's also important to realize that there are poison control centers that you can call. All regions in the US have poison control centers. We did call poison control center for this patient, but they didn't really have much to do because he wasn't symptomatic. So, but it's important to note that they are available, and if you don't have their contact, you can always find out from your emergency department, because the emergency department usually has people with toxic or poison exposures coming there, so they always have it. So, but you can contact them for questions, for advice on how to manage some of these toxic exposures, not just cadmium, but most toxic exposures. So, some hospitals have also used medical toxicologists to provide bedside care for those that are hospitalized in the hospitals. Management of the toxic exposures is usually the major presentation is usually the bone problem or the kidney problems. So they have been treated with dialysis. Some have used high doses of vitamin D to treat them. But the most important thing for most toxic exposures is avoidance. Avoidance, and prevention is the key. And that's what we're going to talk about next. So how do we prevent cadmium exposure? So OSHA has what's something called hierarchy of controls. Hierarchy of controls is looking at how to prevent things, how to control hazard exposure. The best way to prevent exposure to toxic exposure is elimination. Eliminate that toxin in the course of manufacturing, or in the course of the way it's used, that causes it to be exposed to be exposed to the people that are at risk. Another one is substitution. Replace that toxic substance with something that is not toxic or something less toxic. Another one is engineering controls. Isolate the people exposed from that hazard by using engineering or manufacturing, or trying to use some other ways to protect people. So when I talked about using hoods or fume hoods, or using exhaust, all those are using engineering controls to engineer away the source of the exposure from the people that are at risk. Another thing is administrative controls. Administrative controls is when you change the way people work, like you rotate people from one task to another. Like that patient was rotated, he was changed from working in that department, so he never had to handle Cerrobend after that. So that's one of the ways you can rotate people and move them away from where they are being exposed. The last one is PPE, which means personal protective equipment. This is usually the least effective way of managing a source of hazard, because you're only depending on the exposed person to use the PPE properly. And unfortunately, if the person doesn't use it consistently or doesn't use it properly, the hazard will continue to get to them. So that's why it is the least effective. So you have from the most effective to the least effective. So the best is elimination or substitution engineering controls, and all the way down to PPE being the least effective. Other things you can do to reduce some of the risk factors or some of the sources of exposure to cadmium, like avoiding cigarette smoking. And when people think of cigarette smoking, it's not just the person smoking it firsthand. You have secondhand smoking, like my patient was exposed to secondhand smoking from his family members. And there's also third-hand smoking, which is when somebody smokes and the cigarette chemicals and the smoke settles on surfaces, on clothes, on the furniture in the home, and the upholstery in the car, or blinds, the curtains in the home. So when you have the chemicals settling on surfaces, and then the person can touch them and get dermal exposure, because you have to realize that one stick of cigarette has over 7,000 chemicals in it, including cadmium and other chemicals in it. So trying to avoid all sources of cigarette smoking is important. And then check label on fertilizers when you buy them to make sure you're not buying the ones that contain cadmium. And then avoiding working or living near facilities that manage garbage or waste, especially landfills. People that live near landfills, because when people use batteries or use things that contain cadmium, they just dump them in the trash, and all these things go to the landfills. So people that live near landfills are at higher risk of being exposed to cadmium, not just cadmium, but most other toxic exposures too. So I think I will, I've been talking for a long time. I don't even know what time is. So how many minutes do we have, Charlie?
It's 11:45 right now, so it
All
looks like
right,
we have
good.
about
Oh,
15
good
minutes
timing.
left, which is the perfect
So
amount of
that
time for
really
the
is
Kahoot game.
everything I have. And thank you for listening to me. And I can take your questions now before we do the Kahoot. And take my email because the person that wins the highest, that gets the highest score today, is going to email me the screenshot of their score and their email, in it, so that, and their name, so I can send them the gift card, the Amazon gift card for the highest top scorer for today. Any questions before we move on to the Kahoots? I know I
I
talk fast. You probably can understand half of what I'll say.
I had a question regarding PPE. Which type of PPE is most effective for cadmium exposure? I know that's like the least on the hierarchy of like controls, but if that's like the only option you have, what would you recommend?
So for this type of exposure where you're generating particulates, the best type will be to have the full face respirator, because when you have the full face respirator, it has air connected to it. So you're not depending on breathing your immediate air in your immediate environment or immediate surroundings. You're breathing the air supply to the full face respirator. So that would be what I would recommend. And then they could also wear full body coveralls, to protect, the dust getting on their clothes, and then wear gloves, to over that. So that's what I recommend. And then wear shoe coverings too, because those things get on the floor and settle on the floor. And you have to realize these individuals wear the same shoes and go home with it. They go to their offices with it. So wear shoe coverings over their overalls, over their shoes.
I had a quick question, maybe tangentially related to what we talked about today, but I noticed you were also boarded in lifestyle medicine. And I know, like, for exposures, right, it's supportive, right? Like, if someone has cadmium toxicity. So, how much of that training are you able to integrate, like, into your practice? I mean, more so maybe even beyond just like supportive care, but like when you're counseling patients, like what aspects of lifestyle medicine are you really focusing on with your patient population?
Yeah, lifestyle medicine, I apply it in everything. In fact, I'm glad you brought this up because one of the things we're working on is to incorporate lifestyle medicine in occupational medicine. So we actually have a webinar in April coming up on that. I am the co-chair of lifestyle medicine in the workplace through ACLN. So it's really, really very important because if you look at the risk factors I talked about, the risk factors, smoke, diabetes. So diabetes is something, it's a condition that lifestyle medicine can help to reverse. We have a lot of people that are pre-diabetic, a lot of people that are diabetic. If you apply lifestyle medicine, the 6 pillars of lifestyle medicine, you can significantly reduce your risk for developing diabetes. People have been able to reverse their diabetes, through the application of lifestyle medicine because when you apply them consistently, intensively as therapeutic approach, prescriptive, because it's not just telling somebody you have to work out, you have to lose weight. There are therapeutic prescriptive ways of using lifestyle medicine to actually achieve results. And one thing with lifestyle medicine is I actually like it because my patients that I see, like my patient is asymptomatic. So I feel that I'm at an advantage over like internal medicine doctors or primary care who are already having people that are symptomatic. So you are able to intervene before people actually get sick. So the outcomes I have are better because I'm able to intervene before people develop conditions that actually end up uh, taking them to the hospital or taking them to being on medications. I'm able to identify people's risk factors and address them on how to manage those risk factors effectively so that they could limit or reduce their risk of developing health conditions that they might have developed otherwise. So that's one of the things I really like about what I do because I don't have sick people, but I have people that I can actually help to be healthier, improve their health, and be able to continue to be productive and healthy and enjoy their lives, because that's what life is about. Life should be about living it and enjoying it. So that's what healthcare should actually be focused on, keeping people healthy, not waiting until people get sick and then investigating and treating and diagnosing and putting people on medications. That's not what, I think we should be moving further away from that and actually trying to keep people healthy and out of the hospitals.
Yeah, thank you so much for that answer. I'm also very interested in how we can integrate lifestyle medicine into this field. So, I'll be in touch with you. I'll take your email. Thank you.
Absolutely. Thank you. All right, Charlie, how many minutes do we have?
Looks like we only have about 9 minutes left in the
Okay,
scheduled
let's
time.
move.
But if folks can stay on to kind of
All
compete in
right.
that Kahoot
So
game,
let's
that's
do the
great.
cahoots. All right. One of these conditions is not a manifestation of cadmium exposure. Yay! All right. Great. Everybody got it. That's great. All right. That's good. So next one. This one has double points. Which agency designates or classifies substances based on their carcinogenic potential? Yeah, okay. One person got it right. Okay. All right. So next one. All right. Esme is topping the charts. Wow. All right. Next one. Which is the least effective measure for managing hazardous exposures based on OSHA hierarchy of controls? Oh, okay. Well, majority, 75%. Okay, good. All right. So next one. Esme still leading. All right. So we're going to the next one. And we have a bonus question, by the way. So, which of these is not a risk factor for cadmium nephropathy? Wow, 100%. Wow, you guys are really paying attention. Oh my God, that's fantastic. All right. Wow, Tracy's moving up. All right, so next one. Which agency that enforces the standards for evaluating and managing hazardous exposures in the workplace? Whoa, look at you guys. Oh my God, you guys are really, really, really on it today. That's good. All right, Esme is still topping. Oh wow. All right, so we're going to go to, I think I have this is the last one. Yeah, I added one more for extra. I'm always extra, so I like to have extra things. All right. Oh, okay. So remember those three tests we talked about: urine cadmium, blood cadmium, urine beta-2 microglobulin. Yeah, so it's urine culture that is not. So, and that is it. So let's see who got let's see who. Oh! Wow. Yay. All right. This is fantastic. Esme, wow. So take a screenshot and email it to me, and then we'll get you the gift card. Wow. Thank you guys. I hope you guys had as much fun as I did. It's really nice to meet you guys and to talk to you today about what I do.
Thank you.
Thank you so
Thank you
much.
so much, Dr.
Thank
Obi. I
you.
really
And
appreciate you
reach out,
taking the time to do
Maggie.
this.
Yeah, I'm looking forward to hearing from you. Yeah.